Another topic you've mentioned a couple of times now is talking about the need for transplantation and the efficacy of possibly avoiding transplantation with therapy. So what's your experience there? Like you mentioned the word rescue. Is that something that's common in a Wilson disease patient to be able to avoid a liver transplant?
I'll give you an example because in this world we have really three options. We have the penicillamine world, we have the trientine world, of course Couvreur is part of that family, and we have the zinc world. And some are believers in that zinc world. This has been published by Dr. Brewer and the University of Michigan team as zinc as a co-first line therapy after people are decoppered or as you're decoppering those patients. So I think of those things, D-penicillamine's out, trientine is the foundation, and I discuss zinc with patients, but I rarely use zinc just because of the complexity of managing a patient with a chelating agent and zinc. And I've also had experiences that people were switched to zinc alone and had progressive liver disease, and that's where the rescue may have to happen in a patient.
Okay, so maybe inappropriate management. But the fact that the patients could avoid a liver transplant to the point that just treating the copper appropriately and bringing levels down could salvage or have that enough stabilization of their liver to avoid the transplant. I mean, to have that success story.
It's very rewarding. He ended up going to transplant, not from the Wilson disease, but because hepatitis C wasn't curable. And then it became a whole issue. What do you do afterwards? Well, Wilson disease is cured by liver transplant, right? The ultimate genetic therapy. We had to retreat his hepatitis C later with some of the newer therapies. So very unusual case.